All right. Welcome to the Medical Association Facebook Live. My name is Arora. I'm the current president, and I'm here today with our state health officer, Dr. Scott Harris, and the president of the Alabama State Health Hospital Association, Dr. Don Williamson. So welcome to two very important guests as we kind of dive into an update. Dr. Harris, Omicron update and COVID update in general, please.
Sure, happy to do that. And thanks very much for having me. We're very glad to be back with everybody. We've enjoyed doing a lot of these broadcasts over the past few months and haven't done one for a couple of weeks because of the holidays, but it's really good to be back and very glad to have Dr. Williamson. Look forward to hearing from him today as well and hearing about the state of Alabama's hospitals. Most of you who are watching are no doubt aware that we've seen some incredibly high numbers of COVID infection over the past 2 to 3 weeks. We are actually seeing daily case numbers higher than we have ever seen before. We had 2 days this past week where we had more than 8,000 new cases a day for a couple of days. We had another day over 7,000, several others over 4,000 or 5,000, whereas the most really we had ever seen in a single day was about 5,000 to 6,000 once. About a year ago. So we've set new records for the total number of cases. We believe that what we're seeing is the Omicron variant that you probably heard about. We're a little behind in doing the sequencing that will prove that. We don't quite have that data yet, but we do have data from other countries and from other parts of this country where there's a lot more sequencing being done. And given the way this has just exploded and the ease with which it's spreading around, we don't have any doubt about what we're seeing. We're seeing the Omicron variant spread here in Alabama. We had a call earlier today where we listened to the CDC director, Dr. Rochelle Walensky, and she said that more than 90% of all infections in the US over the last week have been the Omicron variant. And in every part of the country, the rate is over 80%. So we're certain that that's mostly what we're seeing right now. Omicron really spreads really easily. It's much more easy to transmit than any of the strains that we have seen before. It can easily be transmitted to people who are vaccinated. The very best protection you have is to be vaccinated and boosted when you're eligible to be boosted. Now, being vaccinated and boosted does protect you against serious illness, against hospitalization. And as far as we can tell so far, it's only been a month now, but it does protect you against death as well, which is consistent with what we know about vaccination and the other strains. But even though it protects you against serious illness and hospitalization and probably death, you certainly can still be infected even though you're vaccinated. So the very best thing you can do is to be vaccinated and boosted, but also don't forget the other common sense things that we encourage people to do. Be very, very careful about getting together in groups of people when they come from different households, and especially if you don't know their vaccination status. Please wear a mask when you're indoors in any kind of public space, and continue to do all the other things that we have encouraged people to do for so long. There is some data now, particularly one study from the UK that suggests that the Omicron variant causes less severe disease than what we've seen with Delta and with some of the previous variants. It's not clear that that's true, but that's looking like that's probably going to turn out to be true. But even though it's probably less serious on an individual basis, the fact that it's so much more infectious means that we're still going to see really large numbers of people who get sick. So, for example, with the Delta variant, about 2% of people who got that infection did not survive. There was about a 2% mortality with the Delta variant. This study from the UK says that the mortality is about half with Omicron. So maybe about 1% of people will die who get Omicron. We're just estimating that because we don't know that for certain yet. But even if the number is 1%, that's so much better than Delta. And yet that's still 10 times more deadly than influenza, than the normal flu that we have every year. And if your Omicron variant is half as causes half the mortality, but you're getting 2 or 3 times as many cases because it's so much more infectious, you're still going to have a lot of sick people who are going to require resources from our hospitals and our healthcare system. You're still going to have a lot of people who don't survive. So Omicron is still a really big concern for us. We've seen it start to decline in places like South Africa. There are hints that it's starting to decline in the UK. Maybe it'll be a quick phenomenon, quick as in, maybe another few weeks before it goes away. We certainly hope that's the case. I just wanted to finally mention just a couple of other things, Dr. Arora. We have had new guidance issued in the past several days by CDC about isolation and quarantine, as you know, and we may get questions about that, but CDC did say that for members of the general public, if you are infected with COVID, and if you're getting better without fever, or if you're just an asymptomatic infected person, by day 5, you can consider going back out into public as long as you can wear a mask appropriately for 5 more days. And they recommend that you consider getting tested as well before you go back after day 5. So that allows a little bit more, allows people to get back to work a little bit faster. They have specifically said that they think the science supports this because people are most infectious in the first couple of days that they become ill. But they have also said that this is a concession just to the huge numbers of people who are getting infected. We need people actually to be able to not sit at home forever. There's absolutely non-medical considerations that went into this. So we still think that staying home for 10 days is the best way to do it. If that's not possible, it is an option for people to get out of isolation after 5 days if they meet those other criteria. They did specifically say that that recommendation does not apply to schools. There is different guidance also for healthcare workers and hospitals. I'm sure we'll talk about that some today as well. But just for the public in general, they do allow for that 5-day quarantine period, isolation period, followed by 5 days of masking. So finally, I'll just say, please get vaccinated. It's not too late. It's the single most important thing you can do to protect yourself and your family. If you have or more than 5 months after your second Pfizer dose, you're eligible now to get boosted. If you're more than 6 months after your Moderna dose, or more than 2 months after your J&J dose, then you're eligible to get boosted. So please do that as soon as possible. Thanks, Dr. Arora.
Oh, absolutely. And I really appreciate your candidness in describing some of the CDC recent guidance and the fact that there was a little bit of confusion with how that was panning out, and whether it was scientific based, whether it was to keep our, keep our world afloat, the realistic nature of a highly contagious infectious variant that's ripping through this fast, right? So, and I appreciate the fact that you've re-mentioned the need for testing after those 5 days, because there was a little bit of confusion at the very beginning of this rollout. And I think that making sure that, the public knows and understands that there is a difference between the community as a whole and then schools, and the fact that that guidance does not apply to schools. Thank you for pointing that out, Dr. Harris. So you did touch on the data so far on possible decoupling, with hospitalizations and cases, but yet, when you're dealing with something so exponential in numbers, like this Omicron variant, and a state like ours, which is not the highest vaccinated, where we're sitting in a very vulnerable place for healthcare in general, COVID related, non-COVID related. So Dr. Williamson, if we can talk and get an update on our hospital situation.
Well, again, thank you, Dr. Arora. It's a pleasure to be here. Thank you, Scott, for a wonderful presentation on the situation. I actually am growing increasingly concerned. I had perhaps wrongly estimated that because Omicron was less deadly, we probably wouldn't see the kind of escalation in hospitalization that we are. But the simple raw numbers of cases is overcoming whatever offset there is in terms of severity. And just to put that in perspective, a month ago on December the 4th, we had a positivity rate of 5.4%. As Dr. Harris has already said, today, a month later, it's 38.5%. That's a number we've never seen before. We had 595 cases a month ago. Today, 7,572. That is a 12-fold increase in cases in 1 month. And for people who think this is simply a common cold, 324 people have died from COVID in the last month. When I turn just to hospitalizations, a month ago, we had 305 people in the hospital. Today, we had 1,249, four-fold increase. And again, while it may be less severe on a population base, for an individual, you don't know how whether you're going to be in the group that stays out of the hospital and stays out of the ICU, or whether you're going to end up in the ICU. And to that end, again, a month ago, we had about 95 people in the ICU. We now have 229. So we've more than doubled the number of people in our ICUs. We've increased by about 45% the percentage of people on ventilators. All of that to say that, to me right now, the most dangerous message that I'm hearing is it's just a cold. It's just the flu. We don't hospitalize people for colds. We rarely hospitalize people for influenza. There were 30 people in the hospital today for influenza. There were 1,247 in the hospital for COVID. This is not under any circumstance something you can equate to influenza or to COVID or to the common cold. And I fear people are going to die as a result of that misperception. To Dr. Harris's point, vaccination remains our best protection. If you look at hospitalizations today, 33.5% of the people in hospital were fully vaccinated, meaning that 67% were largely unvaccinated or a few partially vaccinated. Well, so still in a state with less than 50% of its population fully vaccinated, being vaccinated provides enormous protection. And I don't have the data on boosters, but I would suspect that for those individuals who were boosted, the probability of being in the hospital is even going to be dramatically lower. What I'm probably most concerned about, just looking at the raw data, is the rate of increase is escalating. We only had, for about the first 21 days, right up until Christmas, in fact, we only saw about a 27% increase in cases for the month of December. But over the last 10 days, it's gone up 161%. If you compare the rate of increase now with hospitalizations to the Delta surge, the lines overlap. So, we are seeing now the explosion due to Delta. And even though for a population, only maybe 3% get hospitalized versus 10% with Delta, because the number of cases is so much higher, we're still going to drive up hospitalizations. And God forbid, by the end of this month, we could hit levels we haven't seen since August, September, and maybe even nothing that we've ever seen, including back in January. So, I just want to I'm glad to answer questions, but just mirror the comment that Scott made. The most important thing you can do is be vaccinated. And then the next most important thing you can do is get your booster. But then on top of all of that, you cannot get infected if you do not get exposed. So I just would encourage people, think before you go into a large group indoor gathering. Decide, is it really worth coming down with COVID because you went into a large indoor gathering? And if you decide that it is, then I would say, if you have any chance of escaping getting COVID, you've got to wear a mask. It's not a good idea. It's just, if you're going to go indoors, you've got to wear a mask if you're going into any setting where people are mixing. The last thing is, if I look at the status of our hospital staff, we don't have any more staff than we had during the surge in August and September. In fact, it's probably pretty static. But we have one other thing that's making this more challenging, and that is Delta was more efficiently controlled by the vaccine, and healthcare workers who had been vaccinated were less likely to get breakthrough cases. we are seeing a substantial problem now with healthcare workers having been vaccinated, being breakthrough cases, and as a result, being isolated for a period of time, further reducing the workforce. So the challenge for us is going to be, if we see the same level of cases that we've seen with past surges, it's going to be even more challenging for us to be able to manage and staff those cases. So, we're in a very precarious situation. It's probably going to get much worse before it gets better. But, I think we have an obligation to do the best we can at this point to try to mitigate that. And the way you do that is, again, vaccination and masking.
Dr. Williamson, you hit on some really important points there. I don't think we could do this realistically without following mitigative measures in addition to, of course, the vaccination. We are in a surge right now. The hospitals in my local community, North Alabama, have just, canceled inpatient electives. I mean, this is the real deal. It's not just during Delta. It's not that now we're in a mild situation and everybody's sitting home nursing a cold. It's really impacting all of healthcare, not just COVID care. And of course, our most vulnerable when it comes to COVID with the Omicron variant are the ones in our state who are not vaccinated. And so this is really our plea, our real ultimate plea to anyone who is unvaccinated. Omicron is going to find you. It will find all of us, as a matter of fact. I've come to the acceptance that seeing so many of my colleagues who have avoided getting sick thus far, and in the last 2 weeks, many of them have tested positive for COVID. Thankfully, they have been boosted, and so therefore, most of them are doing okay. But the sad reality of this is that if you are unvaccinated and you contract Omicron, I don't know. We're worried. We are very worried with the path that we are seeing. And so Dr. Williamson is making an excellent point that if you haven't started to get vaccinated, it's never too late to start and get your first vaccine.
We're seeing some things, Dr. Arora, that we saw with Delta. We're seeing increasing number of children in hospital. Today in hospital, we had 37 pediatric patients. We're seeing pregnant women in hospital again, 29 pregnant women in hospital. We didn't, when Delta began to go down, those issues disappeared. We would have no pregnant women, 2 pregnant women in hospital, 2 or 3 kids in hospital. This really is concerning. And, I know Dr. Harris worries. I worry with all of the children now returning to school with very low vaccination rates among 5 to 12-year-olds. We have the possibility and the opportunity, unfortunately, to see dramatic increases in cases among children and then backspread potentially to their parents and grandparents.
I think that right there is the worrisome fact, because the fact of the matter is we're so extremely lowly vaccinated when it comes to children. And there are providers who have told their children, parents of children not necessarily to vaccinate because you can just get COVID and it won't be so bad. But truly now, based on what you just described, I mean, the way this trickling effect could, affect a whole community is really going to be quite tragic, and something that hopefully we can mitigate. The simplest, easiest way to mitigate at this point in time, of course, is to wear a mask, a good quality mask at that. I'm sure if you've tuned into any news station, you're starting to see a little bit of education to the public that probably should have been there at the very beginning about the type of mask for these, how to prevent getting a contagious virus, right? And so making sure that you have a KN95, making sure you have something that is going to protect you, not necessarily a cloth mask is going to protect you from Omicron if you are unvaccinated, and staying away from large crowded places right now if you are unvaccinated in particular. I think that's an important message. So going back to schools, we've had some questions about schools, with the level of unvaccinated children in our state. What are you foreseeing, with this is the first week going back to school? What is kind of the worst expected scenario, the best case scenario? What can we do to potentially go, best case scenario? Because you know, a lot of schools have opened. Many have changed to include masking. But again, not everybody is wearing the same type of mask, right? So any thoughts?
Yeah, I think we're all probably like both of you, I'm staying up nights wondering how this is going to turn out. There are a couple of things that haven't changed at all. One is our understanding of how this disease gets transmitted. When you take a bunch of people from different households, particularly if they're unvaccinated, and you put them together indoors for long periods of time, not wearing masks in the middle of a pandemic, I mean, I don't think we're surprised at what's going to happen. We're going to see many, many, many cases of COVID. That's inevitable. It's already happening. The other thing that hasn't changed is our guidance on that. We still strongly support universal masking in all our K through 12 schools. We strongly urge parents to have their children vaccinated as soon as they possibly can. None of that has changed. Now, I certainly understand parents are between a rock and a hard place here. Our public officials, our school boards are really in a tough situation. We all want kids to be in school and for face-to-face instruction. We want them there in person. That's the best way to do it. There's so many reasons how we've seen in the past 2 years that being out of school, being in a virtual environment is just not the same. But we also want to be able to do it safely. And so our guidance has not really changed that much. We continue to promote the school toolkit that we have. We want people to use masks. We think that that's a really effective, pretty easy strategy. Don't know why so many people get so worked up about it. It's unfortunate. And we want people to be vaccinated. And again, honestly, don't know why so many people get so worked up about it. It's very straightforward science to us, and that's what we continue to recommend.
I think that makes good sense. That's excellent advice. Can we talk a little bit about the kind of what also keeps most of us awake at night, which is as these numbers of cases continue to kind of compound and the lack of treatments that are appropriate in our hands to treat patients the way that potentially we had during the Delta surge. Can we talk a little bit about the availability of monoclonal antibodies and the kind of monoclonal antibodies that really are out there for this particular virus, sotrovimab and Paxlovid, of course, the oral pill?
Sure, I'll start, and Dr. Williamson may want to add some things as well. For those of you that, you probably remember us talking about this on several occasions before, but monoclonal antibodies are antibodies that are created in the laboratory that you can take as an IV infusion when we find out that you're infected with COVID. And it allows, it's sort of like an artificial immune system that gets injected into you right away so that your body can start fighting an infection. A vaccine actually works the same way. The vaccine is a natural way that your body produces antibodies, but it takes a couple of weeks for those antibodies to build up. And so once you're infected, vaccinating you at that point is not going to be helpful right away. It's not going to be helpful in the next, 10 days or 2 weeks when people, usually become the most sick. So that's why we use these artificial or monoclonal antibodies that are made in a laboratory. Because particularly if people aren't vaccinated, they're not going to have any other protection. So far, we've had other monoclonal products out there that have been used for all the strains of COVID that we've seen before, up to and including the Delta variant that caused the surge in the summer. But now that we have Omicron, we actually only have one monoclonal product now that's effective for this variant, for the Omicron variant. The name of that drug is called sotrovimab. It's hard to remember how to say that, but you don't have to remember. It's just the S drug, and it's the only one left now that's still effective for people that are infected with COVID. Up until a couple of weeks ago, we still had some Delta circulating nationally, and probably a sizable amount here in Alabama. So all of those antibody products, monoclonal antibody products, were options. But at this point, sotrovimab is the only one that's likely to be effective. We use that in people who are infected, who are at high risk for getting really sick or going in the hospital or worse. That tends to be people that are seniors or people that have chronic health problems. The big issue right now is that there's not enough to go around. This is a familiar theme we've heard over and over during the last 2 years, whether it's vaccines or testing supplies or anything else. All states are getting an allocation of this sotrovimab. from the federal government. We're only getting a few hundred cases. I think the number was 400 doses, 420 doses this week. We're getting those doses about once a week, so just a few hundred. Remember, we just pointed out that we've had sometimes 8,000 cases in a single day of COVID infection, but we're getting about 400 doses of this medication per week. So not nearly enough to go around. We certainly hope that the manufacturers will figure out how to make more of it soon.
Yeah, I think the number of cases that you mentioned and the number of doses, let's hope that we don't end up where we don't have doses for people who are really sick, right? And that's ultimately what we want to avoid. So if we can keep infections from happening, that's really the part that is in our control right now, because we aren't getting any more shipments. So we want to be very clear to the public right now when we say that if you are unvaccinated or if you are vaccinated and high risk and immunocompromised, there is not a quick pill. I've had some reach outs from non-medical friends who have gotten COVID this past week and avoided it, for this 2.5-year period. And they're looking for a monoclonal antibody that can just make it better. And it's sad that we have to say, no, there isn't anything right now, but that's the reality of this time period. We don't have anything and our numbers are bad. So Dr. Williamson, you look like you're about to.
The only point I was going to make is to put this in perspective. I don't think there's any question, but the only thing that kept our hospitals functioning and operational during the Delta surge was the use of monoclonal antibodies. Right. And so it is truly another reason for anxiety for those of us who are looking at these hospital numbers. If we don't have sotrovimab as an effective agent in adequate quantities, as these numbers continue to rise, we're going to be in a situation where some people who could have avoided hospitalization are going to end up being hospitalized. And that is just the way you don't want this to go.
That's a great point.
The percentage was quite high too, right? With the monoclonals.
Yeah, I mean, I saw numbers all over the place, but easily you can say that 70% of the people who got monoclonals didn't end up hospitalized. Right. And I've seen some data as high as 85%, but clearly getting monoclonals early in the course of illness kept you out of the hospital. The problem is we just don't have, as Dr. Harris just pointed out, we got 400 doses for a week, in a week that we probably are going to have 35,000 cases.
Right, absolutely. Okay, so we've got a few questions that have come in. One is, Dr. Harris, can you help parents and school boards? Is there a way that we can order masks like some other states have been doing for students?
I know the State Department of Education had those available last year. They had that as a budget item and had masks available. I don't know currently if that's the case, but thank you for asking me. What I'll do is I'll ask our team about that, and then I can get back with you either our next broadcast or we can get the message out on the Facebook page. But I'll do my best to find out an answer to that question.
Yeah, I think that's a great question, and thank you for looking into it. And then, as far as Evishield, can we talk a little bit about that and immunocompromised patients?
Sure, that's a great question. So Evishield is also a monoclonal antibody, but it's used differently than the other monoclonals that we've been talking about. This is not a drug that's used for people who are infected with COVID. It's actually used as a way to prevent infection with COVID in people who don't have good immune systems. So the people we know who are really most at risk for serious illness are those people who have immune systems that don't work properly because, let's say, they may be on chemotherapy for cancer, or they may have some genetic reason that their immune system doesn't function properly. Certain people with chronic illnesses, some chronic illnesses like end-stage renal disease, for example, are also people who are more prone to serious illness from infections. And so that group of people, even though we're trying to encourage them to get vaccinated, the vaccines probably don't work very well in most of those people. And so we're trying to find other ways to protect them. We do encourage them to get vaccinated anyway, but we're trying to find other ways to protect them. And that's where Evusheld fits in. It's an injectable monoclonal antibody that people can take every 3 months as an injection, and it stays on board to fight infection in case you get infected, in case you get exposed. So it's what we term pre-exposure prophylaxis. We actually have Evusheld right now available only in a couple of really limited locations, but it's supposed to start shipping more widely next week. We've been waiting on the feds to essentially validate all of these different people who are ordering the product. So we'll have a few thousand doses of Evusheld in the state next week. Again, probably not nearly enough to go around, but we estimate that somewhere around 2 to 3% of Alabamians are people that would be candidates for this drug. These are people that have real significant immune suppression issues.
Thank you for that update. Can we talk a little bit, since we're talking about treatments, about oral Paxlovid and the ability if somebody was to test positive, what they would do and how we are doing in terms of shipments of Paxlovid. I know we weren't doing so great as of last week.
Yeah, so this is a story that's very similar to the one that we just told about sotrovimab. There are 2 oral antiviral medications that have been recently granted emergency use authorization to be used in high-risk patients who get infected with COVID. So you can think of this as an oral way to get some treatment early in the same way that we try to give monoclonal antibodies early to patients before they get sick. The 2 products, one is called molnupiravir. It's made by Merck, and it actually has, after all the data has been reviewed, has been shown to probably not be real highly effective. It's probably not as good a drug as the other oral drug, which is made by Pfizer and is called Paxlovid. Paxlovid is thought to reduce your chance of being hospitalized between 80 and 90% if you're able to take it early in the course of your infection. And again, that's a drug that we're hoping to reserve for those people at highest risk for getting sick or being hospitalized. The problem, again, same song, next verse, is there's just not enough to go around. So this week in Alabama, we got about, I think around 700 courses of this medication. We actually only get this medication shipped every 2 weeks. So we're getting about 700 doses every couple of weeks. And again, we're having thousands of patients every day who are testing positive. It's difficult to know how to allocate that. It is a prescription drug, so a physician's got to see you and diagnose you with COVID and write a prescription for you, and then you have to go get it filled at a pharmacy. But because there's so few doses available, those doses right now are being managed by a federal retail pharmacy partner, which is Walmart. And Walmart was chosen because they're in a lot of different rural communities. Because it's one single pharmacy chain, we have a real good ability to see how much drug is located in the state at any given time and where it's located, and even have the ability to ask them to move it from one part of the state to another in case we need that in certain areas. But the truth is 700 doses don't last long. They last for a day or two and then they're gone. So we're told that in the next few weeks, that supply is going to go up, just like we heard back when vaccines were first rolling out. We think that amount will increase at some point, but right now there's just not enough to go around.
Yeah.
I think the way I've thought about Paxlovid is it's sort of like the Tamiflu,
right?
COVID. If once we get adequate supplies of Paxlovid, it has the ability to, I think, be a game changer.
Right.
The problem is it's probably not going to be a game changer for this spike, because we're just likely not going to get enough of it quickly enough to have an impact on what we're dealing with now.
I think that's exactly right. I think the big message here, it seems, is timing is everything. And so if we can be as vigilant as we possibly could, I know that's a hard ask, but after 2+ years of being in a COVID pandemic, everybody wants to kind of do what they need to do. But we're just pleading for now, for this period of time where we do not have a monoclonal antibody, we do not have that oral pill that Dr. Williamson and Dr. Harris were just telling us about. And the things that we can do are wear a mask of good quality, get a vaccine, get a booster, and really keep ourselves very vigilant in large crowds and large gatherings.
Just to comment, I mean, and Scott probably knows this certainly better than I do, but my sense on this is the reason that these are in short supply is simply a function of manufacturing. Yeah. The manufacturer simply just can't turn out the doses as quickly as we need them, because probably nobody at the time these were being developed ever anticipated the Omicron situation and this kind of transmission. I mean, it's not like Alabama's being punished in some way. It's just there isn't enough being produced, and we're getting our proportional allocation.
Yeah, I think that's a very good point to bring up. It's true.
Exactly right.
Can we talk a little bit about rapid testing? I know that's also been kind of a little bit of a buzz lately.
Sure. I'll say, testing of all kinds is in short supply right now, and every state in the country is dealing with that problem. We're coming out with this, for example, shortened isolation time guidance, and telling people to go get tested, even though these are all people we already know who got tested 5 days ago and they're positive. So we're coming up with all kinds of ways to use lots more tests. We have schools getting back into place. We're trying to do testing in those environments. There's testing going on routinely in nursing home populations and so on. So there's a huge demand for testing, not to mention the fact we've got this new variant that's making thousands of people sick every day. These 8,000 people who tested positive yesterday and the day before, they pretty much went because they were sick. That's probably why they got tested. They weren't just randomly checking themselves. So we don't have enough testing of any kind right now, and that's a big problem. The feds have said, the president himself actually spoke last week and revealed the plan to have about 500 million at-home tests shipped directly to Americans sometime soon. I don't know if that's going to come soon enough to help us with this spike, but we hope in the next few weeks that each state will learn more about how that's done. We really hope public health doesn't get put in charge of it for our state, but we probably will. So we'll have to figure out how to mail all of these test kits to everybody's home. But there are, as you mentioned, at-home tests, rapid tests that can be done as well. Those are pretty tough to find right now. I tried to find one in the past week or so for somebody in my family, and it's harder than you think to track those things down. The commercial pharmacies, private pharmacies, commercial pharmacies, chain pharmacies all tend to have those, but they tend to, be in pretty short supply, and it's not easy to get them sometimes. I'll remind you that all our public health departments in every county in Alabama are doing testing every single day in every single county. As well as vaccinations every single day in every single county. We don't necessarily do it all day long, 8 to 5. It may be, only in the morning or only in the afternoon. So you might want to call if you think you need a test there. But that's done at no charge, and it's done in every county every day at public health departments. I'll say before Dr. Williamson speaks, we don't want you going to the emergency room to get tested, please, not unless you're sick enough that you need to be seen at the hospital. The emergency room should be for people who are having emergencies. And if you think might need to be in the hospital, or your doctor thinks that, then by all means, you need to go to the hospital. But if you just need a test for work or a test for travel, or you just have a sore throat and think you need a test, please don't go to the hospitals. They have a lot going on right now, and that's not the place you ought to go.
Yeah, thanks, Scott. That was going to be my point. I get it. People want to be tested, but the emergency department is probably the worst place to go just to get a routine test. You're going to be there longer. If you're infected, you may expose other people. If you're not infected, sitting in a waiting room, you may get exposed. And on top of all of that, you slow down the processing of everybody else who needs health care. So I would just, I follow up with what Scott said. If you want to be tested, unless you are ill, seek an urgent care center, seek your physician's office, go to a county health department. There are providers, pharmacies, there are providers doing mass testing. Seek out some of those. You'll get seen more quickly, and you'll have less effect on the healthcare system overall.
Absolutely. The ER colleagues across the state would much appreciate that message. Right. The waits in the ERs right now are beyond what we have seen in the pandemic thus far. And I think the ambulance is trying to unload patients. The whole thing is just really upside down right now. So that is a very strong message. So if you need to get tested, not the ER, that is the message for that. Well, I appreciate both of you. Is there any last minute message? I see that it is kind of time probably to wrap things up.
I'll just throw in, as you know, my parting words here. You know, all these issues we've talked about difficulty in getting tested and difficulty in getting these monoclonal antibodies and short supply for these oral medicines, you know, all the stress on our hospital systems, all those are problems because people are getting infected, and maybe they don't have to get infected if they could just get vaccinated and try to wear masks, try to stay out of public spaces, try to do the things to prevent themselves. We don't have to expend those kind of resources on people who aren't infected.
I think that is great.
I think all of us would like to move on to another topic other than COVID.
That's right. I know. I said I'm starting to get sick of doing this. I feel like I'm being the COVID lady. I want to go back to regular life.
Yeah, but Dr. Harris's point is exactly that. You know, get vaccinated, get a booster, wear a mask. You'll do yourself a favor, your family a favor. There's no reason not to.
And really, I know I've heard a little bit of criticism about, you know, whether people should get vaccines right now because they're starting to see their vaccinated and boosted friends get Omicron, but their vaccinated and boosted friends are not getting really sick and having to be in the hospital and having severe, you know, illness. But if you are unvaccinated, we have no ability to promise you that. And on top of that, as healthcare providers, it is painful to tell you that there is no treatment at this current time. So please get vaccinated.
Look, we'd love to say vaccines prevent everything. Very few vaccines are 100%.
Right.
You know, if we compare this with the influenza vaccine, it's substantially better than the influenza vaccine. So, yeah, I mean, to your point, people who've been vaccinated and boosted may get COVID, but they are very unlikely to be in the hospital. They're even less likely to be in the ICU, and they're even less likely to die. On the other hand, for the unvaccinated, we can't say that.
Right.
And as you pointed out, we don't have a therapy right now, or we have very little sotrovimab to give them. So they may well be on their own.
Right.
Absolutely. You don't wear a seatbelt because it keeps you from having a wreck, right? You wear a seatbelt so you don't die in case you have a wreck.
Right. That's right. So it's not a pleasant message to have to deliver, but we'd rather people have that message in front of them before they are sitting in a place of desperate need.
Sure.
So that is our only message for today. So we do care about you, and that is why we're here. It's really not because we love COVID. So thank you both for your time, and I appreciate it. And thank you for tuning in.
Thank you.